Well, 1 in 10 women of reproductive age have polycystic ovarian syndrome. That's a condition that can cause menstrual irregularities, fertility concerns, weight gain, and more. Yet, despite its prevalence, PCOS is underdiagnosed and misunderstood. So joining us live now for this Wellness Wednesday to debunk outdated assumptions about PCOS is fertility expert Dr. Marjorie Dixon. Dr. Dixon, welcome back to CP24 Breakfast. It's been a while. Great to see you.
Thank you for having me back.
Absolutely. So let's talk about PCOS. We gave a brief intro, but maybe you can go into further detail about, the women that it affects and what symptoms you should be looking for if you suspect that you do have it.
Right. So the acronym PCOS stands for polycystic ovarian syndrome. And really it's heralded by a category of 3 findings. And this was determined by the Rotterdam criteria, which was in Rotterdam in the Netherlands, where experts in PCOS came together because we needed to have a proper way of diagnosing and then being able to treat it.
Right.
So number 1 is to have irregular menstrual cycles. So a lot of young women, older women have irregular menstrual cycles. That's one of the criteria. The second criteria is having polycystic appearing ovaries. So that means that your ovaries have a typical appearance on ultrasound, which sometimes people call a strand of pearls, like a little circles around, because you're not ovulating regularly.
Right.
So it's like the eggs get trapped. Sometimes it also even looks like a chocolate chip cookie. It can be all interspersed, but those are little potential eggs coming out that don't come out. That's polycystic ovaries. And then the third one is having high androgens. Androgens are male hormones. Women have them as well, but they manifest either in the blood, so biochemical, or clinically. And clinically means that you would have more hair than the average woman. Sometimes you'd have male pattern baldness. You might have acne. So signs of what we call hyperandrogenism, high male hormones. So you need 2 out of those 3 for a diagnosis.
Okay, so let's say you're a woman and, you're reaching that age where you're thinking, oh my gosh, perimenopause or menopause, my period is changing. It's different than what it used to be. Is that cause for concern? At that point, should you go to your doctor and say, give me a blood test, check me out, ultrasound? Like, what's the first step a woman should take?
So that's different. That is sort of the change in your cycles and the irregularity that comes when your ovaries start to stop working and ovulate regularly. This is during your reproductive lifespan. PCOS is that irregular ovulation that happens in adolescence as you're getting into your period and actually through your reproductive times. And one of the most common myths is that people will come to me and say, I was referred to you because I know that I'm going to be infertile because I was told I have PCOS. And that's a myth. Because you ovulate irregularly. Some of these women ovulate irregularly. If you're having regular intercourse, you are at risk of potentially getting pregnant. So it's those kind of myths that need to be debunked.
Right.
And women need to understand that there's a spectrum of illness. So it's not just those 3 Rotterdam criteria, but it's the lifelong effects metabolically that can happen that can put women at risk, and you need to know about them. So one of those is insulin resistance and the risk of developing diabetes over your lifetime, or cardiovascular disease that's associated with PCOS, or a higher prevalence of anxiety and depression that can come along with PCOS, or a propensity to easily weight gain with PCOS, and then things that can help you. So there are medications. When women aren't regularly ovulating, they're exposed to estrogen, which grows the lining of the uterus. If you're not shedding it every month with regular ovulation and menstruation, you could be at risk of developing endometrial cancer.
Right, okay.
So that needs to be protected. So sometimes you get cyclic progesterone to shed the lining.
Wow.
Or you get put on the pill. The issue with being put on the pill to regulate your cycles is sometimes women mistake that for, now I'm ovulating, I'm fixed. It doesn't solve things.
But it's a Band-Aid, yeah.
It treats it, and it's good. But what matters is the education around all of this. Because PCOS isn't a capture in time. It's over your reproductive lifespan. And it's something that you can deal with into your perimenopause and menopause, putting you at risk of things like heart disease and diabetes and insulin resistance. So the importance is to understand it. The importance is to be with healthcare providers that are fertility specialists, but reproductive endocrinologists, like we are at Inova, that understand the spectrum of the disease. That's why it's so often misdiagnosed, because it can be a bit of a chameleon.
Yeah.
Right? So you have to rule out other things, diagnose it properly, help your patient understand that when you're on the pill or when you're on progesterone, it doesn't solve the problem. This is a lifelong thing. And also beware, because women are complex, and this is a spectrum of disease. So whilst there are medical fixes, there are also lifestyle fixes, and those things work in concert. So when you see an influencer on social media that'll say, I'll cure your PCOS because I had PCOS and I did this one diet and I was fixed, that might be important. Like, lifestyle management is key to women's health. However, you have to be aware of the magic that someone will say that purports that this is going to cure your PCOS. PCOS is complicated. It requires a proper diagnosis, a doctor that understands, lifetime management, and overall wellness considerations so that women can get the best outcomes possible. And that's why we have to talk about it, because it's complicated.
Absolutely. Yeah, you really need to get the full picture and the proper diagnosis before it can be treated. Otherwise, you know, it's just a whole cloud of misinformation. And there's a lot of it out there. Okay, Dr. Marjorie Dixon, that is our time this morning. Thank you so much for this informative discussion. Appreciate you coming down, and have a good day at work. Take care.
Thank you for having me.
Thank you so much.